Hello, everybody. It's Friday, October 3rd. Welcome to Grand Rounds, presented by the Department of Psychiatry and Behavioral Sciences. Welcome once again. While everyone is logging on, I'll introduce myself. My name is Jed Thompson. I'm the Associate Director of Communications for the department, and I'm happy to be here hosting Grand Rounds for you today. We've got a great talk. Want to get to that as soon as we can, but while people are joining us, I'll go over some of the basic logistics of our program before we meet today's presenters. You probably heard the message when you logged on that we are recording today's presentation, so we will have this available online in our archive sometimes this afternoon, might be on Monday. But that'll be in there along with all of our other videos. So check out our archive. And if you're in the archive right now and you're watching a recording, hello from 2020-25. Um, a couple more things. We will have a Q&A feature going. It's at the bottom of your screen there. We may or may not have time for questions at the end, but if you do have any questions that come up, go ahead, type those in the Q&A, and if we have time, we'll answer those at the end of the presentation. We also have a survey, so if you want to give us any feedback, what you thought today, any ideas for future grand rounds, let us know. There'll be a link to our survey that will appear on your screen as soon as the presentation ends. The webinar closes and the link will be there, so let us know. And next week, October 10th, Dr. Stephen Thilke will be joining us, and he'll be talking, he'll be giving a presentation called How to Look Forward to Getting Older. So today we're learning about youth. Next week, we'll be talking about older adults. So we like to cover the whole spectrum here at Grand Rounds. So please plan to join us for that. Okay. Yeah, I think I've gone through all my logistics. So let's move on to the next slide there. And let's meet today's presenters. To do that, I'm going to hand it over to the chair of our department, Dr. Jürgen Unitzer, and he's going to introduce you to our guests today. So Jürgen, I hand it off to you now.
All right, well, thank you, Jed. Welcome everybody to Grand Rounds in Psychiatry and Behavioral Sciences. Today, we're going to hear from two of our own, Drs. Alicia Thompson and Shannon Simmons. And Alicia and Shannon are going to talk with us about updates in acute care and inpatient care for children and adolescents. And I'm really looking forward to this presentation, but before I hand it over to our speakers, let me just take a few moments to introduce them. We'll start with Dr. Thompson. Dr. Thompson is the clinical director and an attending psychologist on the Psychiatry and Behavioral Medicine unit at Seattle Children's Hospital. She's an associate professor in our department, and she's a real expert in working with youth who are experiencing mental health crises, trauma, and suicidality. And she does that work here locally, but she also works with colleagues regionally and nationally on ways to improve acute care, intensive care for children and youth with those kinds of needs. She has authored a number of publications that mostly focus on inpatient psychiatric treatment for youth. And she has co-authored, recently co-edited a really neat handbook of evidence-based inpatient mental health programs for children and adolescents. She's also a great teacher, and she's a tremendous advocate here in our region for improving mental health services for youth. Dr. Simmons is also an associate professor in our department, and she serves as the medical director of the PBMU unit at Seattle Children's Hospital, actually of that unit and all acute mental health services at Seattle Children's Hospital. She is also an associate training director for inpatient psychiatry in our child psychiatry fellowship program. And she is a co-editor with Dr. Thompson on this handbook of evidence-based inpatient mental health programs for children and adolescents. She's also authored a number of other publications in this area. She has served as the recent past president of the Washington State Council of Child and Adolescent Psychiatry, and she's active regionally and nationally in the American Academy of Child and Adolescent Psychiatry. There are many more things I could say about our two speakers, but the most important thing I can do is to get out of their way and to welcome Drs. Thompson and Simmons to our Grand Rounds in Psychiatry and Behavioral Sciences. It's all yours.
Thank you, Jürgen. Hello, everybody from up the street or down the street, depending on where you are located right now. I know that sometimes our worlds can feel pretty far apart, even though we are geographically close. So I hope that this talk helps us feel a little more connected to what's happening in the world of child psychiatry, both at a national level, but also at a local and regional level. So I did want to start with the disclosure that we do receive royalties from Springer for the handbook that Jürgen mentioned, and here's a picture of the cover. We also wanted to take a moment to acknowledge and thank the staff and clinicians that we work with at Seattle Children's Hospital in the Psychiatry and Behavioral Medicine Unit. It's a really challenging work environment, but also very rewarding, and it takes just so much dedication and commitment. So we wanted to take a moment to, again, acknowledge and thank everybody that we work alongside while doing this very challenging but very important work. As we were thinking about exactly what to focus on with this talk, it was a little bit challenging because there has been so much change, so many challenges, and also so much growth within our field over the past few years that it wasn't an easy topic to wrangle. So what we decided to do was to organize this talk around three main issues or challenges, and within each of those, share a little bit of the latest research, evidence-based, et cetera, and then also share some of the innovations that we've done here, locally and regionally, and that also have, maybe taken place nationally, as well as future opportunities. So the three challenges, there were many to choose from, I'll add, but the three challenges that we decided to focus on today were: one, the increase in psychiatric acuity amongst youth; two, the challenge of barriers to discharge from the hospital; and three, how to incorporate measurement-based care within a fast-paced acute inpatient unit. So I'll kick us off by talking about the first challenge, which is the rise in psychiatric acuity. This is something you've probably heard about. You may have witnessed it firsthand in some of the clinical work that you do. It's even made it to the national media. The big picture is that the suicide rate, unfortunately for youth, has been increasing for several years now. There's been some focus on how the COVID pandemic accelerated or brought light to this, but I really think it's important to note that this trend was happening quite a bit before COVID. As of 2023, as you can see in the chart on the right, 9% of all high school students actually attempted suicide in the past year. And that rate was even higher for certain groups, as you can see, such as females, American Indian or Alaska Natives, Native Hawaiians or Pacific Islanders, or LGBTQ youth. And again, this is people who actually attempted suicide. If you look at the same survey for the question about seriously considered suicide within the past year, the numbers are essentially double this. So again, just really, really high numbers of teenagers who are really not doing well. Along with this, there has been an increase, as you could imagine, of people coming to the emergency department seeking urgent mental health assessment and care. There was an over 50% increase, for example, from 2011 to 2015, and then an additional 50% increase, according to the Children's Hospital Association, from 2019 to 2022. So again, I'll emphasize, you can see that these trends did predate COVID. I just want to emphasize that, but they've unfortunately really just continued year after year. So as a result of all these trends, you might recall that in 2021, a few kind of high profile things happened. One thing that happened was that there was a joint declaration of a nationwide mental health crisis for youth in October of 2021 by the American Academy of Child and Adolescent Psychiatry, or ACAP, the American Academy of Pediatrics, and the Children's Hospital Association. Additionally, also in late 2021, the Surgeon General released an advisory about youth mental health. And this did garner an increase in focus on the issue. So, this 50-page advisory, it has some really important and really appropriate guidance. But we're talking about things like provide a continuum of supports to meet student mental health needs, expand social and emotional learning programs that promote healthy development. So don't get me wrong, I'm very much in favor of those things. But those things are not going to go into place right away. And even if they did, they're not going to do a whole lot for the children who are actively in our care, seeking our care for an acute mental health crisis right now. So I will now turn it over to Alicia to share some of the specific details about things that we have done over the past years in order to respond to this crisis for the youth that are seeking our care and under our care right now.
Thanks so much, Shannon. So one of the things that's a challenge is the lack of evidence-based approaches specific to inpatient psychiatry units. And so one of the things that we do is we pull from the literature in other similar areas. And one of those areas is from schools. And from schools, we learn a lot about positive behavior interventions and supports. And there's emerging evidence that this can be an effective tool in inpatient psychiatry units for children and adolescents. And so about almost 3 years ago now, we implemented positive behavior interventions and supports on our unit. This is an evidence-based, proactive, preventative approach that has been found to reduce the use of restraint and other more disciplinary practices, not only in inpatient psychiatry settings, but also schools and juvenile detention. And it includes a number of things. The first is this agreed upon tier of interventions, which you'll see here, with the bottom tier being our universal preventative work that we are doing for everybody. And that includes having what we call a behavior expectation matrix. We want kids to know what is expected of them, so then they can rise to meet our expectations. And then we reinforce that through positive behavioral reinforcement and really clear label praise, like you are doing the right thing and the thing we want to do. And that's also connected to our token economy. Kids on our unit get stamps connected to that label praise, and then they can cash their stamps in for prizes at the end of each day. And that is one of the ways that we help to kind of build and shape learning around the behaviors that we want to see. Within this tiered support system, the idea is that those universal supports are supporting everybody on our unit. Our universal supports on the inpatient unit are a little bit more intensive than they might be at an elementary school, simply because the kids who come to our unit need a little bit more intensive supports, right? And then in tier 2, we've got more targeted interventions, and our last tier is more intensive interventions, where we might have one-to-one staffing, a really clear behavior plan, those types of things. The focus is very much on creating a positive climate to reduce disruptive behaviors. We use data to make decisions about how things are working, not only for the whole unit, but also at the individual level for each of our kiddos. Next slide, please. So how's it working? Since we've implemented PBIS in March 2023, we have seen the following reductions related to restraint: a 14.8% reduction in the total time in restraint per 1,000 patient hours, and a 54% reduction in restraint duration per event. So our restraint time is getting much shorter. That's less time at risk for kids for risk of trauma, risk of injury, and ultimately the risk of restraint is death. We want to avoid it as much as we can. We've also seen a reduction in disparities in restraint by race. And what you can see on the left is a picture of the guidebook that each of our kiddos get. You can see on the right-hand side is the behavior matrix with really clear expectations. They know what to expect. It's clearly laid out for them. They've also got some things like feelings thermometers, coping plan, and the artwork is designed by one of our PBMU staff members, which is really wonderful. And it's really great to see all of the kids come with it nicely colored to groups, so that way they are each making it their own. Next slide. So we are also working on improving our milieu programming. My philosophy is that a bored kid is an unsafe kid. That is true not only on the inpatient unit, but other places as well. And so engaging patients in fun educational activities not only helps to build their skills, it also keeps them engaged and helps prevent safety events. And so our team over the past 5 years has really dramatically expanded our programming and added a number of group and individual offerings, including art therapy, music therapy. Every kiddo gets at least an hour of school or education time daily. We have therapeutic gaming, where they're playing both video games and board games, card games, as a way to engage in therapy. We have multiple therapy groups per day in DBT and CBT skills led by our master's level mental health therapists. We have recreation therapy, occupational therapy. We're adding speech therapy in the coming months, which I'm very excited about, as well as spiritual care. So lots of improved milieu programming, both at the individual and group level, to really keep kids engaged in their programming and their treatment. Kids are not in their rooms. They are in programming all day, every day, in order to get them to engage in behavioral activation, in order to get them out of their room, and to prevent safety events. Next slide. We also, in March 2023, opened our biobehavioral inpatient program, and this is a program I'm really proud of. We are, as you can see on this map, this study was literally published this week, so I'm excited I was able to include it. we contributed data for it, but we are one of the few inpatient programs in the country that provides care to youth with severe intellectual and developmental disabilities who are engaging in high-rate self-injurious behaviors, engaging in aggression as a means of communication. Many of these youth are non-speaking. And as you can see, looking at this map, we are one of very few programs, and the nearest closest programs to us are in Las Vegas and Colorado. They're far away. We're the only program in the WAMI region, and we are literally having folks drive from all over the state to reach us. And we've also served folks from other states as well. And in this program, we have patients staffed with one-to-one staffing, primarily by certified behavior technicians, and they receive applied behavior analysis by board certified behavior analysts. What's been key here is having experts in this area treating youth who have these very specific problems, and we've dramatically improved the care we're providing for these youth. And we've also changed the layout of our unit that includes specially designed space with treatment rooms with a one-way mirror, a sensory gym, as well as an adaptive exam room, which is pretty exciting. Next slide, please. One of the other new things that we've implemented this year is behavioral personal protective equipment. So given that we see lots of youth who are engaging in high-rate self-injurious behaviors as well as aggression, we need to protect not only the patients we're serving, but also our staff. And there has been emerging evidence that this has promised to reduce restraint and staff injuries. And we are also one of the units that's sort of on the forefront of using this strategy. So we have implemented the use of Kevlar sleeves. Those are those Gillis sleeves that you can see there. They help prevent injury from bites, as well as helmets in our biobehavioral program. And we've also used it in other programs with patients who have a severe history of aggression, so that way we can protect staff. We are continuing to monitor the impact on staff safety and injuries, and we have seen some promising impact specifically on reducing staff head injuries. And we also have implemented and are exploring further options for behavioral personal protective equipment for patients. So we have many patients who are wearing their own helmets to prevent their own head injuries, arm splints to prevent their ability to self-injure, that kind of thing. Next slide. Another thing we've implemented is called Ukeru. Ukeru is a trauma-informed blocking pad system. We implemented this in February 2024. It has been found in other facilities to reduce the use of restraint. And the idea is that if you have a patient who is becoming aggressive, you can have a blocking pad between you and the patient to prevent the patient from injuring you and also prevent the need from going hands-on. We also can use those smaller pads you can see with the little handles on the side to prevent self-injurious behavior such as head banging, or put it in between the patient who's head banging and the wall or the floor to reduce the likelihood of injury. Next slide. Another thing that we have done is create what are called adjunct guidelines of care. These are standard processes based on evidence-based practice to really address common problem behaviors and support unique needs to ensure consistency across our staff. Rather than having an individual behavior plan for any kid who is ingesting foreign bodies, as an example, they get the standard guideline of care, and then staff are responding in a consistent fashion. And since we've implemented our intentional foreign body ingestion adjunct guideline of care as one example, we've dramatically reduced the amount of foreign body ingestion that's happened on our unit. Swallowing non-food items, right? Pen caps and broken pieces of plastic, those types of things. We also have created specific ones to support unique needs. So for our neurodevelopmental disorders adjunct guideline of care, we've got planned time and room to take breaks to make sure kids are not overstimulated, visual schedules, those types of things. And then we've also identified specific problem behaviors that are an impact not only to the patient, but also to others. So identity-based aggression, when a kiddo is using a racial slur, we have a very clear set way that we are responding, knowing that that is pretty harmful to other kids in the group, and that can prevent other kids from potentially becoming aggressive if they're not being the target of identity-based aggression, as an example. And so you can see we've got quite a list of adjunct guidelines of care that we've implemented and developed for our unit. Next slide.
Yeah, I'll chime in here and tell you about this. So Seattle Children's Hospital has around 80 clinical standard work pathways, and they cover topics, everything from managing acute appendicitis to urinary tract infections. So there was a small team of us that spent about a year all in total creating this pathway through review of the existing literature, which is relatively sparse, to be honest with you, looking at peer institution resources, looking at standard practice approaches, that sort of thing, to come up with this clinical standard work pathway for managing acute episodes of agitation and aggression. It includes both behavioral and medication interventions, and also specific ways that certain specific diagnoses or clinical presentations, such as autism spectrum disorder or acute substance intoxication, might influence the interventions that you chose. It's available on the Seattle Children's external website, so just like all clinical standard work pathways. So if you wanted to review it or utilize it in some site that you're working at, you're more than welcome to go to seattlechildrens.org and just search for CSW and you can find it there.
So we've got some more opportunities. We've done lots of work and there's still more work to be done. So one of the things that we're working on now is implementing a risk assessment tool to identify both staffing needs and behavioral personal protective equipment needs upon admission. Continued assessment regarding the impact of improvements made. We want to know if the interventions we're doing are working, and if they're not, we want to make sure we're tweaking them accordingly, and coming up with new interventions that might be needed to help reduce restraint and staff injury and make sure kids are getting the care that we need. And we also need to work on, as a larger system, building out the continuum of care for youth, especially for youth with severe intellectual and developmental disabilities and youth for externalizing behaviors. We've seen the continuum of care grow for youth with suicidal ideation, which is wonderful, with the addition of partial hospital programs as an example. And we still need more, especially for these specific groups. And then continuing to work on building out our capacity to manage severe and acute behaviors in the existing lower levels of care through training and collaboration. And so for an example, Dr. Eric Bolter is the program psychologist for a biobehavioral inpatient program. He's partnering with a local residential program to ensure that they're getting trained to be able to manage these kids in this facility. And we also have folks in our larger department who do training with wraparound and intensive services, or WISE.
Great. So that brings us to our second challenge. So I'll start by saying that the issue of emergency department boarding has received a lot of attention through local media, through ACAP, through emergency medicine, academic groups, and even in the national media. This has definitely had some kind of high profile stories, but that's not what we're going to focus on. We're going to focus on kind of a different aspect of boarding that gets less attention, although I will say that Alicia and I were aware of this issue back in 2021 and published on it. And this is the issue of kids who are actually boarding for discharge while admitted to a psychiatric hospital. So again, a little bit of a different spin on boarding. We usually talk about emergency department boarding, but this is a little bit of a different topic. In some ways, I think it's just as impactful, if not more impactful, to the overall healthcare ecosystem, as well as to the individual patient. So we wanted to talk about this in more detail, and I'm relieved that my animation worked, so that's great. So first, I wanted to take a few minutes to be clear about which patient population we're talking about. So this is youth that came to the, let's say, emergency department in crisis. They initially met criteria for inpatient hospitalization. They were admitted. They received treatment in the hospital. They stabilized. They reached the point that they're ready to discharge. However, for reasons that I'm going to talk more about in an upcoming slide, they have nowhere to go, and thus they stay in the hospital. It's important really for us to call out that at any moment in time, we on average over the past year have had between 4 and 10 patients who fall into this category on our unit. We are a 41-bed unit, and so that's up to a quarter of our beds are being occupied right now for youth who really don't need that level of care, but remain there because they have nowhere else to go. You can also see from these visuals that both our unit and just overall statewide, the percentage of kids with longer length of stays, so 30 days in the line graph from the Seattle Times, it's DOH data, and 60 days as the cutoff kind of in our data, which is the one with the bar graph, that has increased steadily over time. So more kids are staying for longer, and we're pretty confident that this is largely driven by this issue that we're talking about now. So why does this happen? I think there are a few root causes that we can talk about. The first thing I wanted to just remind you all is that we're talking here about children and teens, sometimes young children and sometimes youth who have severe or moderate intellectual and developmental differences. So in adult psychiatry, if somebody had nowhere to leave the hospital to, they would potentially be discharged, not ideally, of course, but to a shelter or to the street. And that's just not an option when we're talking about children. It's extremely rare that there is a patient who is appropriate for going to a shelter, and that's not even to speak to the very limited capacity for appropriate adolescent shelters in the region. So again, if they have nowhere safe to go, then in the vast majority of cases, they just by default have to remain in the hospital. So, in terms of why this is happening, we often hear from parents and caregivers that they are not willing to pick up their child because they really do not feel that they have the supports and the resources in the community to provide for their child's long-term chronic needs. And it's true that treatment capacity has really not increased at the same rate as the volume of patients needing treatment. The treatment capacity just has not kept up with the demand. Additionally, one thing we did see during the COVID pandemic was that some of the more intensive treatment interventions, such as in-home behavioral supports or applied behavioral analysis, those went away for quite a while because of at the time concerns about infection and that sort of thing. And I really think that has had a lasting impact on patients and families who really need those really robust, intensive community and home-based supports. Some other factors are that we've seen a few other adolescent inpatient units around the state close over the past few years, meaning that there's just fewer inpatient beds overall. And so that kind of amplifies the impact that this has. One way that amplifies the impact is that, one, I think it makes it harder for people to get crisis stabilization when they need it, which means they might go longer before they seek treatment, so that when they do, things are in a more acute state. And that leaves everybody feeling more hopeless, and the treatment needs have just increased. Additionally, since there are just fewer beds overall, the patients that do fall into this category end up being concentrated, if you will, at fewer institutions. And I will note that we are the only hospital in the state that treats younger children and treats youth with autism with moderate to severe intellectual or developmental disability. So by default, Seattle Children's is more or less the only place that treats those children. There's also really just frankly not enough longer-term residential programs within the state of Washington, specifically for some of these patient populations that we've mentioned again and again. Something else I wanted to mention is related to the role of the Department of Children, Youth, and Families, or Child Protective Services. So in years past, if a child was at the hospital, they were stable for discharge, but their parent or caregiver was not agreeing to pick them up, CPS would at times come and take the child into protective custody. Is that ideal? No, of course not. Is that what any of us want for children? No, of course not. But one of the I hate to say positive, but one of the positive things about it was that kids were not stuck at a hospital far beyond needing that level of care. Several years ago, we started to notice that this was happening less and less. And we heard the same from colleagues around the region. What we were hearing when we would call in these situations is that the child was in a safe place, they were not recklessly abandoned, and thus no action would be taken. This Seattle Times article that I have a screenshot of on the slide goes into some more detail about this issue and some of the other kind of recent factors that may have contributed to this. But at the end of the day, one of the recent changes over the past few years that contributed to the problem we're talking about, in my opinion, has been this apparent change in practice about CPS no longer taking custody of children who are ready to discharge, but their parents are not picking them up for whatever reason. So I wanted to also spend a little time talking about why this matters, in addition to the pretty obvious problem of a limited precious bed is being taken up by a child who just doesn't need that when there are others that do, right? The first challenge we encounter is a cycle that we have seen dozens, hundreds, maybe thousands of times over the past few years. We are designed around roughly an average 1 week or so length of stay. Things start to get extremely repetitive and extremely boring after a few times through that. You heard mentioned earlier that our school in the PBMU is essentially an hour a day of school-like instruction. So kids have access to a small patio, but it's quite small, and that's more or less the only outdoor time. So you can just imagine how this is not an environment that's built for a long length of stay if a patient is remotely safe to be discharged from the hospital. what we start to see is that, kids start to become really frustrated and demoralized. We typically tell kids that the way to get out of the hospital is to be safe, work on their safety, and they'll be able to go home. But that ends up not being true for these kids. And they really start to have mistrust of the system, mistrust of the adults in their life, and again, get really frustrated. This often leads to then an uptick in behavior, like safety events or behavioral events, even if that child had actually been stabilized for a little bit. They start to get frustrated and things start to go downhill again. That in turn makes it even harder to discharge them. We may hear from a residential facility who was previously, willing to consider them, oh, well, now they're too acute, so we're going to have to say no. Or we may hear from potential caregivers or family, this is why we can't take them home because they're too acute for us to manage, that sort of thing. So it really becomes this pretty vicious cycle. Some other challenges I wanted to mention that are a little bit unique to kids and teens is that behaviors are contagious. So if one peer is really off track, having a hard time being safe, engaging in, let's say, oppositional, defiant behavior, there's definitely a small subset of kids who, in other circumstances, probably would have gone with the flow, been on track, been, pretty compliant with expectations. But now they're going to join in on the unsafe behavior. They're going to join in their peer on being oppositional, on being off track. And sometimes this can become quite the snowball effect and can really destabilize the entire unit. I also think it's important to notice and acknowledge that this issue is really reflective, unfortunately, of established and known healthcare disparities. Specifically, this happens more to youth who have an autism or IDD diagnosis, who identify as Black or Hispanic, and or have Medicaid. So I think that really, also points to specific areas where clearly more resources, both for treatment, are needed. So what have we done about that? We've done a number of things. I think the first thing we had to do was really work hard with all of our teams, all of our clinicians, so that we all had a shared mental model of who these patients are. I think if we're not consistent in our definition of this and identifying these patients, it's really hard to take consistent action and get any traction or movement. We also had to adjust a lot of our daily operations and processes to help identify these patients and then to respond and do action planning in the specific situation. So one example of that is that we have a daily high acuity huddle on the PBMU where we routinely talk about patients that, let's say, had more than one safety event in the past 24 hours. We've also added a schedule each day of the week. There's a different subset of patients where we talk about anybody whose length of stay is a bit above our average. And that helps us understand what is still keeping them in the hospital. Is this a situation where now they are stabilized and it's more of a barriers to discharge situation? And what sort of action planning or escalation needs to happen to move things along in that regard? We also actually created a policy about how to respond in these situations to ensure that all of us were handling these situations in a pretty standard way. This includes a tiered approach based on pretty standard criteria. It ensured quick escalation both to unit and service and even hospital leaders at some times, as well as to the appropriate agencies and services to try to mobilize supports and mobilize a response. There's like a schedule for huddles and all sorts of things within that. Even in the couple of years since we created that, the ecosystem, if you will, has evolved. So we're going to be taking on a revision of that policy, but I think it was a really important step, again, to really standardize our kind of approach and response, if you will, to these situations. We also did some things within Epic, which is our electronic health record, to help with the tracking of these situations. So on the individual patient level, on the screen in the bottom right, you can see a navigator that we have built out. So for each individual patient, you would put in what was the date that they were medically ready for discharge? What is the recommended level of care? Who are the agencies that are involved? What are the specific barriers that have been identified? What are the referrals underway? That sort of thing. These individual navigators then actually feed to a patient list. So at any moment in time, I could pull up that list and say, hey, we have 7 patients on the barriers to discharge list right now, and little so-and-so has been medically cleared for 17 days and they still have no discharge plan in sight. That comes in real handy when we're talking with legislators, when we're talking to insurance companies, to leadership within other child and family facing agencies, that sort of thing, to really help highlight this problem. That patient list also feeds into dashboards that help us with tracking this data over time, which again has been really, really critical for the advocacy work that needs to happen to move this along. All right, Alicia, I think you're going to speak to this one.
Yeah, so another thing that we have done is really create a assessment service by our psychology team. One of the gaps that we've been seeing is getting timely access to outpatient care, specifically for youth who we suspect have an autism diagnosis, as an example, but don't have it confirmed. And in Washington State, in order to access ABA services, applied behavior analysis, you have to have the confirmed diagnosis. And so that was preventing us from getting kids access to the timely care that they needed. So what started as me and psychology residents from our UW psychology internship program, as well as practicum students, has evolved into multiple full-time folks, who psychologists on our team, who are conducting timely assessment on a number of different things, but including autism evaluation, as well as assessment for eligibility for developmental disabilities administration services, although now it's DDCS. And that has been key to unlocking services for youth who would otherwise not be able to access them, or we would be referring to a 6-month to year-long wait list to get assessed, right? And so if we can do the assessment on our unit in a timely way, that allows us to then be able to get kids connected to services more quickly. And then the other thing that we see a lot of is that we get kids whose behavioral acuity is such that when assessments have been attempted to be completed in the community, such as schools or outpatient clinics, they can't be completed in the one day that they've got set aside to do that, because those kids just can't tolerate sitting for a long assessment. And so on the inpatient unit, we're able to check in, and here's the best time of day to get them assessed for when they're most regulated, and also break it into much smaller chunks over time to be able to make sure that we're able to complete a thorough assessment. So since we have meaningfully had more than just me as psychologist on the inpatient unit, we've completed over 200 assessments in the last 3 years, which is about 10% of admissions of kiddos who we've been able to get tested and then get connected to more timely care, which is really, really exciting, and a big testament to the psychologists on our team who have been doing that work.
There is some good news. Thanks to a lot of really strong advocacy by the government affairs folks at Children's, as well as some specific people within our mental and behavioral health service line. In 2023, the Washington State Legislature passed a bill. We call it to create a new care coordination team. We call it the 1580 team, named after the bill. Maybe not the most creative name, but that's what stuck. And this group has accountability to the governor's office, and they are responsible for helping overcome these discharge barriers for these exact youth. The team includes representatives from all the appropriate youth and family-facing agencies who are involved in these patients, such as the Developmental Disabilities Association, whichever various insurance, Medicaid, etc. group is involved, school systems, that sort of thing. They have a lot of really creative and innovative things that they've been able to do to really help move some cases along. For example, they have a flexible funding account that has served as a really important way to resolve some discharge barriers that came at a cost for which there was no traditional funding mechanism. An example might be that a family says, we're willing to have him home, but we need to have alarms and locks on the doors, and we need to make some repairs to XYZ space in order for it to be a safe place. There's no way that an insurance company is going to pay for those things, but the flexible funds from the 1580 team may be able to help provide for those repairs. Another example might be, let's imagine a youth was accepted to a residential facility out of state, and he really needs 2 caregivers or support people to travel with them. An insurance company is not going to pay for that. Maybe they'll pay for 1 caregiver and a child, but definitely not 2. And we've seen the 1580 team be able to help chip in and help contribute to those kind of transportation barriers. They're, again, a little bit outside of the traditional things that would be reimbursed for. They've also done a great job of getting the right decision makers at the table. Who among us has not been at a care planning meeting with people that were well-meaning and doing a great job, but just not able to do anything outside of a certain set of things, or work outside of the box, or things like that. So the empowerment of this group, again, to do things a little bit off the beaten path and a little more creatively has been really, really key to moving some really challenging situations. I also wanted to include this screenshot instead of one of the Seattle Time ones because it has some of our local Seattle children's folks here with Governor Inslee. On the far left is Kashi Aurora, who's a program manager for our service line. Next is Alicia. And then after that is Dr. Sina Shaw, my child psychiatry colleague, who's the attending for the biobehavioral program. So nice picture and nice write-up of this team that we've really been grateful to partner with. Nonetheless, there are still a lot of opportunities. I think the biggest challenge, honestly, is going to be how do we maintain these gains and continue to gain more in times of budgetary and financial challenges. I think that's really something that's weighing on a lot of people moving forward, and we're going to have to see how that goes, right? Additionally, continuing to provide the day-to-day care for these patients when they are in the hospital beyond what they need for sometimes really extended periods of time is incredibly challenging and takes so much perseverance, creativity, resource, etc. So we're going to continue to work as much as we can on innovating in their care while they do remain in the hospital. Ultimately, at risk of already becoming a broken record within this talk, ultimately the way this problem is going to be improved is by investing resource and building out the care continuum, especially in the more acute services such as brief crisis stabilization opportunities, more intensive outpatient and partial hospitalization programs, more in-state residential programs so people don't have to send their child across the country to get longer term care, and more robust behavioral supports, applied behavioral analysis, especially for youth with ASD and IDD, but really across the diagnostic spectrum.
Right. Our last challenge is measurement-based care in a fast-paced setting. How do we know if what we're doing is working for the kids that we're working with? There's a lot of challenges with measurement-based care in our setting. In general, most measures will say, in the last 2 weeks or in the last 6 months, have you observed these things? When our length of stay is a week and we're asking about in the last 2 weeks, we're not going to notice any change, right? The timeframes are longer than inpatient admission. And then given the nature of acute crisis stabilization, we're actually not expecting that we are going to dramatically impact somebody's symptoms of depression in just a week. The goal of our unit is really to stabilize the acute crisis and then make sure you're connected to the most appropriate services after you're here. And so we're not expecting that we're going to dramatically improve somebody's symptoms of depression, as an example. We also know that self and parent report measures can be flawed. First, many of our patients can't read or communicate verbally, so having them fill out a self-report measure is not going to be very helpful. There's also very little validation in the literature for the use of these measures in inpatient psychiatry. And given how acute and severe the mental illness is for youth on our unit, there's huge ceiling and floor effects. So most of the time when we have done lots of self and parent report measures before, which we did do in the past, we would see parents and kids rate themselves as really high on everything because they're in a lot of distress and they are experiencing really severe and significant symptoms of their mental illness. And so given those ceiling and floor effects, it would be really hard to tangle through, okay, what's the most pressing concern for this family if they're high on everything, right? And we did do this for some time where we had a pretty big battery of self and parent report measures that we had folks fill out on admission. And what we found is that families had a hard time thinking about it in the moment, in crisis, in the emergency department. It was not the first thing that they were thinking about completing. They were really just trying to settle into the ED and talk about what was going on. And so we had kind of a low return on people actually completing them. And then given those ceiling and floor effects, our clinical team was also thinking about, well, how do we make sense of all of these? And so given all of those concerns, we have moved more toward really looking at specific behavioral targets on the next slide. And so as we're tracking behavioral targets, this is data tracking by our direct care staff, either our pediatric mental health specialists, our nurses, or our certified behavior technicians. And they are looking at specific operationalized behaviors every 15 minutes in our biobehavioral program where there's that one-to-one staffing, or every 2 hours in our child and adolescent programs. We have very clear standardized operational definitions and scores based on observable behaviors, with the idea being that if I walk into the room and observe a behavior, I would give it the same score that Shannon would if she were to walk into the room. And we're able to use this to track patient behaviors over time. So here's a quick snapshot of what observable behaviors look like on our unit for a kiddo. We pull the data from Epic flow sheets into Tableau, for those of you who are familiar with those software systems. And the blue lines are the percentage of time over the course of the day that a kiddo is engaging in those observable target behaviors. So the top one for this kid was aggressive behaviors. We also have identity-based aggression, which started midway through the admission, so we added it as a target to then be able to track. And we have irritability. Those red lines, those phase lines, are specific either behavioral or medication interventions that were made. So then we can see with those phase lines, hey, are our interventions making an impact? And then we use this data to be able to talk about daily changes to medications or behavior plans, to be able to talk with families about progress that we're seeing, and to be able to communicate to our outside partners, our community partners who are going to be receiving kids back into their care, how things are going. And so this has been a really effective way for us to think about how kids are doing in our setting and readiness for discharge, the impact of our intervention, that kind of thing. In addition to tracking behavioral targets, we've also created something new on our unit, which I'm pretty excited about. And this is creating an acuity tool. So this was born out of the need to be able to communicate acuity. We were living on vibes for a while where, the vibe was, oh, it's acute today, or not so acute today. And we didn't have data to be able to say, here's why the vibe is that it's acute today. And also, the data we did have was restraint data. And the problem with only restraint data for acuity is that it was often used as both the independent and the dependent variable. Our unit is acute because we are having so many restraints. We have so many restraints because it's acute. It was a chicken egg kind of problem. And so what we needed to do was be able to figure out, well, what are all of the other things that might be adding to acuity? And so this was a huge collaboration between our nursing teams, our psychology teams, and our psychiatry team to really think about what are the pieces that impact both behavioral acuity, but also what are the nursing interventions that then can help decrease acuity, and also pull staff time and are necessary to be able to support managing the care for that patient. So we started with a previously created tool, Johns Hopkins. They published as a poster so far. There isn't really anything else in the literature. And we took what they had and we made some adaptations. For one, theirs was a paper pencil measure. I did not want anything that would add to the nursing burden for our staff. So everything had to be automated. So what happens on our unit is that at midnight, it's actually 12:06 p.m. The flow sheet auto scores all of these different variables, which you can see on the left-hand side, that we believe are related to both behavioral acuity and nursing needs that impact acuity. And we added key nursing variables that indicate that high nursing need. They're scheduled meds. Some of our kids need really creative ways to get them to take their scheduled meds. This one has to be crushed and mixed in applesauce as one example, because they don't like the taste. And so those types of things take extra nursing effort. And if we don't do it that way, can lead to behavioral acuity. But if we do that way, put in the extra effort up front, can be preventative to prevent future acuity. We also wanted to add the standardly charted behavioral targets that we thought represented behavioral acuity. As you can see, we've got physical aggression, property destruction, disrobing, disruption in the milieu, elopement, identity-based aggression, problematic sexualized behaviors, self-injurious behaviors as our behavioral targets that feed into this. And then we also wanted restraint data. We do have a standardized assessment that is completed each shift by our nurses, which is the dynamic appraisal of situational aggression, the DASA, that also feeds into that data as well. And so what's really cool about this is a hover. So in the patient list, I can hover over the acuity score for each kid, and I can see which pieces of acuity are impacting their acuity score for this day. And for now, we have them labeled red if they're 20 or above. If it's under 20, it's orange. If it's under 10, it's green. That fits the vibes. It's very face valid. And we've got some more work to do to really validate this measure, given that we made it up. It's something that we created on our unit, and it's got lots of great face validity, but still lots of work to be done to continue to validate it in the inpatient setting. Next slide. So next steps, we have ongoing work to continue to build into clinical team members' workflows the clinical utility of those tools, pulling up those graphs, being able to analyze them, see how things are going in terms of medication management, behavior planning, that kind of thing. We also need to validate these measures and look at the factor structure of the Acuity tool is one of my next goals. Creating database cutoffs rather than vibes for our high, medium, low acuity. And really moving past the pilot phase of the Acuity tool regarding staffing decision-making. One of the things I didn't show you is we do have also an EPIC report that can pull acuity by nurse and by program to be able to look at, well, which of our nurses is getting a lot of acuity right now, and can we make sure that we are intentionally staffing differently so that way we're not having one nurse with the most acute patients all at once, or if they do have the most acute patients, that they only have a couple rather than having a large number of them. And then we also are continuing to explore which tools might be best to use for outcomes data here, and also think about what other tools do we need to create given that there's not lots of good validated measures in this setting. All right, so that brings us to sort of our conclusions and next steps. We have thrown a lot at you in a quick period of time. But some things that we have seen work, advocacy efforts, like our work with the 1580 team, really does make a big impact. It's absolutely crucial for us to get involved and make sure that folks at the state level are knowing what we are seeing and how that's impacting children and their families, and what we think can be done to help improve things. Collaboration with other inpatient institutions has been so key to learning from others in an area where the literature is sparse. And, one of the things Shannon and I've kind of joked about is, co-editing this book was really wonderful. And some days we just wish there was somebody else to ask a question to. And when you're the one who co-edited the book, that means that there's not a deep bench of folks, right? And so what that's meant is that we have really done a lot to collaborate with other institutions, those authors and many of those chapters in our books, to ask them, hey, what are you doing? Sending out to listservs, what behavioral PPE are you using? Can you share with us the type of helmet that you source? So that way we can, in real time, learn from others, not wait until all of us have free time to write a paper to let it hit the literature, as an example. We are really excited about the growth and expansion of subacute programs at Seattle Children's over the next few years to really build out our continuum of care. We've seen growth of our partial hospital program as one example, and that has done great work to support youth with severe and acute mental illness, and we know there's more to come, and we're very excited about that. And we also know that there are areas in the community that are building those as well. Ongoing partnership across disciplines within our unit has been so necessary. We are not an island in one specific discipline. We have to work together in order to make change. And I am so grateful for the partnerships that we have across disciplines on our unit to really be able to move work forward and to share our varied experience and expertise and perspectives to really make change. It's been really wonderful. I can't say enough about hiring and growing the right people. We have an incredible team at Seattle Children's of really dedicated, passionate people who are really smart and really have lots of great expertise and experience working with these kids and their families. And having a strong, committed team with the expertise in the areas we need it really makes all the difference. And then lastly, data tracking. I love data. The data is telling us how things are going. We have to be able to continue to use that to communicate problems internally to our own teams, externally to our partners, and then continue to assess if our interventions are addressing the problems identified. So lots of work continuing to happen. We're very excited to have been able to share it all with you today, and happy to take some questions from you. Thanks, folks.
A ton of references too, if you would like more info on any of these things.
All right, thank you. That was fantastic. And look at that, we do have time for some questions. So that worked out well. We got through it. Yeah, so folks, go ahead and type your questions in the Q&A. It looks like we have a huge crowd out there today, which is amazing. So I'm sure we do have some people that have some questions. And look at that as I speak. So let me read this out loud so everyone online knows what the question is. Okay. Do you start discharge planning with families as soon as children are checked in?
Yes.
Absolutely. And I think one of the things that we can't do is wait until the behavior is stabilized before we start discharge planning, because discharge planning takes a tremendous amount of effort to be able to connect kids to the right services. Wait lists are long. If we're not starting that from day one, it's a real big missed opportunity. And in many instances, our case managers in the emergency department are even starting that work before they even get to us on the PBMU. So absolutely, our case management team does the most work with this to really make sure that kids are getting connected to timely services, and that has to start on day one. Otherwise, we're just going to prolong inpatient hospitalization.
Yeah. All right, great. And maybe while we're waiting for some more questions to come in, maybe you can tell us where we can find your book. Where can we get that?
Springer
Sold by Springer.
Publishing,
Yeah, Springer.
Springer Publishing. All right.
and they've got an online and a hard copy version. And online, you can buy one chapter at a time.
Oh. All right, folks. Any other questions out there?
Jed, I have a question.
Sure.
So first of all, I want to thank our two presenters for a really fabulous overview of a lot of really good and really hard work that you have both helped do and helped lead at Seattle Children's over the last couple of years. This is challenging work, and I think you have to be smart. You have to have a lot of courage and dedication to do this. Share with us a little bit about what has helped you sort of do that, what's helped you stick with it, how you support each other and other team members on the unit to do this difficult work.
That's a great question, Jürgen, and I think a really important one, because it has been a really challenging, number of years working in this space, and the headwinds have not always been on our side. And so I think for me, what's been helpful is just continuing to remember that I am privileged to do this work. I have a choice in what I do, and I choose to come and do this. And as challenging it is for us as workforce members, it's even more challenging when you think about the kids and the families that are in these really challenging situations. And so if there are things that if we can find energy and motivation in that to try to make life better, to try to make their suffering a little bit less, then I think that's really, really important. I also think working as a team, I think acknowledging wins, even really small ones when they happen, I think those are all really important things as well, because it's definitely been, it's years now that we've been, that the mental health crisis was declared, right? And things were not going well for even a long time before that. So it's definitely a marathon and not a sprint. And so I think continuing to reflect on the things that give us joy and satisfaction from the work is important. To rely on our partners in the work is really important as well.
I want to echo all that Shannon said. We actually start our morning with we call it safety huddle, where we talk about safety concerns for people's awareness. And the last thing we talk about is our shout outs and celebrations. So that way we can capture those little wins. We have to acknowledge and recognize those. Otherwise, this job can feel a little punishing sometimes, because it's a lot of hard work to do. And as Shannon said, some of those headwinds aren't always in our favor. And having a good, strong team really makes all the difference. So that way, if you're having a hard day, you've got a partner that you can rely on to say, hey, I need to talk about this, or I've got a problem that I need to work out. And I've been really grateful for our team here at Seattle Children's that we can really rely on each other for those things. And also the connections that we have made to folks at other inpatient units that I can call and say, we're really struggling with this. What have you done in this situation? And one, get validation that we're not the only inpatient unit struggling with this. And two, get some fresh ideas and fresh perspective on what we might do a little differently.
Well, thank you. It's really, really inspiring to hear sort of what you have taken on. Thank you.
Yeah, I think we have time for one more question that just came up here. So I'll go ahead and ask this one, which is, management and data analysis is commendable, as is concern for safety. How are ACA and individual developmental factors addressed?
I'm wondering if this is referring to development of staff, of patients. I might be having a hard time understanding the question. I'm sorry.
I can start talking about individual patient developmental factors, and we are constantly looking at each kiddo as an individual and factoring in what are each kid's developmental needs, cognitive needs, trauma histories that are then impacting the behaviors that we see. And as we think about what those impacts are, making changes to their behavior plans accordingly, making sure we're educating staff on what that kiddo's needs are, so that way we can tailor our interventions accordingly.
Okay, and I think I will just do one more question here, which is someone is wondering which discipline or person on your team is keeping track of the measurement-based data for the patients.
Yeah, it's a team effort, and our psychology team members are doing some of that work. Our board certified behavior analysts are doing a lot of that work in our biobehavioral program. Our psychiatrists are taking a look at that. Our nurse practitioners are taking a look at it. And it's not necessarily one specific person owning that work. And I think that's something we can continue to work on and improve.
And some of the reason that is that, Alicia, you and your team have built a lot of these things so that they are happening in an automated fashion, you know, like pulling from Epic flow sheets and that sort of thing. And so nobody is responsible on a day-to-day and hour-to-hour basis of tabulating things and finding a place to put it and that sort of thing. It's automatically happening, and we have our health records set up so that is at everybody's fingertips, so that they are able to make best use of that. So that, I think, has made it really usable by all disciplines across the board.
All right, well, thank you both for being here today. It's really good to hear about what's happening at Seattle Children's Hospital, and judging by the size of our crowd today, there was clearly a lot of interest in what you're doing. So really appreciate that. Great to have you both. Thank you, everyone who joined us, and we'll see you next week. Have a good weekend.
Thanks so much, folks.
Thank you.